what are you going to do with that information? Is it going to terrify you and you're going to be at the doctor every day wanting a scan? Or are you going to be proactive and use that information to be powerful?
This is A New Angle, and I'm your host, Justin Angle, marketing professor at the University of Montana. This podcast is my chance to speak with cool people doing awesome things in and around the great state of Montana. We are proudly underwritten by First Security Bank and Blackfoot. Hey folks, welcome back and thanks for tuning in. I'm speaking today with Michelle Weaver Knowles. Michelle is a nurse practitioner who recently established her own practice, Ava Health. She helps patients navigate cancer and understand the genetics associated with many cancers. Michelle's personal story that led her to this work is powerful, and you can understand why she dedicated herself to helping others deal with the complex storm of emotions and bureaucracy they encounter when dealing with a cancer diagnosis. Beyond that, our conversation surfaces some incredibly complex questions that all of us, and our society in general, will have to grapple with. Communication and decision-making in families can be challenging. Layer on top of that the insights that genetics can offer, and it makes your head spin a bit. How should aspiring parents make decisions based on test results? What ethical obligations do parents have to inform their children of genetic test results? And what about people who learn their parents are not who they think they are, or that they have relatives they weren't aware of? These are just but a few of the incredibly difficult questions, the surface of which this conversation just begins to scratch. I learned a ton from Michelle, and I think that you will too. So let's get into it right now. Okay, so we're here today with Michelle Weaver Knowles. Michelle, thanks for coming on the podcast.
I know, super excited.
Yeah, so you are you've been a nurse for a long time, but you've sort of recently become a nurse practitioner. Can you just tell us the distinction between those two things? I don't really know the difference.
So nurse kind of is a big umbrella. There's people that are medical assistants that have gone to a trade school for a little while. They typically work in doctor's offices, and that's actually how I started out, and I worked on the postpartum unit.
Okay.
Then while I was going to nursing school, I worked as a medical assistant. There's also LPNs, which is a licensed practical nurse, and that's usually a year and a half or so of school. There's master's, bachelor's, doctorate, associate degree nurses, and that just all has to do with how much time you went to school. An associate's degree nurse, the order it kind of goes in is associate degree, bachelor's. So you have a bachelor's in nursing practice, which is what I was for about 35 years. And then I decided I could do more for patients if I got my nurse practitioner, which it can either be a master's or a doctorate degree. So because I was older when I went back to school, master's was a 3-year program, and I wanted to get out there and help people, so I chose to do a master's degree, and I graduated about a year and a half ago from Gonzaga.
Fantastic. And since then, you have launched Ava Health, right?
I have.
And so tell us all about that.
So one of the reasons I really wanted to become a nurse practitioner is to be able to write my own orders and take care of patients, because I was frustrated with that as a nurse. As just a regular nurse, you can't write orders, you can't make diagnoses.
And when you say write orders, what does that mean?
I can't write a prescription for a medication to a pharmacy if I needed to refer you to a dietitian, or I needed you to have a mammogram
scan.
Okay. I couldn't do that as a nurse. I knew what to do, but I just couldn't write the order and be the ordering provider, scope of practice. Yeah.
And so you wanted to go back to get some more education, and then you did that. You became a nurse practitioner and launched Ava Health. And what is Ava Health about?
So I chose to do a family nurse practitioner so that I wouldn't limit myself to the patients that I can take care of. So I can take care of newborn to elderly as a family nurse practitioner, and I can take care of men and women. So there's different designations of nurse practitioners. You could just be a women's health nurse practitioner. Okay. And actually Gonzaga called me up and said, why are you doing family nurse practitioner? Why aren't you doing a women's nurse practitioner program? Because that's your whole entire nursing career. So one of my big reasons for launching Ava Health is to be able to do genetic cancer risk assessment, we call it, for hereditary cancers. And I wanted to be able to take care of women and men, because men can have these hereditary cancers as well.
Yeah, I want to kind of get into that as we go. So you've had a particularly personal experience with breast cancer, and that's guided a lot of your career. Can you talk about that a little bit, your past, and how that's informed your career choices?
So my younger sister, Sherry, was 30 years old, and she had just finished breastfeeding a baby. It was her third boy, and she happened to do a breast exam in the shower and felt a breast lump.
Okay.
So at age 30, she was diagnosed with breast cancer, and unfortunately, she died when she was 33 years old, and that was after a mastectomy and some chemo and bone marrow and stem cell transplants. So a pretty...
She fought hard for a long time.
She did, and it was a pretty traumatic thing to watch.
Yeah.
And really hard, too, for me emotionally because I'm the older sister and I'm the nurse. Why couldn't I protect her from that and take care of her? So I have a lot of guilt about that. And I think being able to help other people and channel it that way, and had to finally realize that she lives on in my heart and in my hands. And every patient I touch is in her memory, and hopefully they can feel that, and I help them.
And you share the same genes.
We do.
Yeah.
So about 4 years after she died at age 38, I was diagnosed with breast cancer. My girls were 14 and 10, and I was the typical Hellgate band parent, president, nurse, working hard,
doing
all
stuff.
those mom things. And it was pretty devastating, especially since my sister had just died.
Yeah.
I'll never forget my daughter, Madison, who was 10 at the time, saying, Mommy, are you going to die like Aunt Sherry did?
Yeah.
Or the fear in my husband's face thinking, wow, am I going to be a widow at this young age like my brother-in-law?
Right.
So that was pretty terrifying. So I was diagnosed in 1998. The BRCA, or BRCA genes, people call them, are two genes that we see a lot in breast and ovarian cancer. And you'll hear me say this a lot because there's other cancers, too, that are related to that. Pancreatic, melanoma, and male breast cancer, and prostate cancer. So I was diagnosed with that in 1998. That gene mutation, that gene had just been discovered in 1996 by Mary Claire King, so pretty new. I worked in an OBGYN office at the time and asked my physician that I worked for to go ahead and do that testing on me because I wanted to know for information for my kids.
Had your sister had the testing?
No, because she died in 94 and it wasn't discovered till 96.
Oh, okay. Wow.
So when we look at hereditary cancers too, we look at different patterns. And one of the patterns in my family and in a lot of BRCA1 families or families where there are other hereditary cancers is young age at onset of a cancer. And in my particular one, it's something that has to do with the breast pathology report called a triple negative breast cancer.
Okay.
So that means the estrogen, the progesterone, and the HER2 testing were all negative. And those are generally more aggressive cancers. We don't have as many things to treat them with, and that they are sometimes associated with BRCA cancers.
Okay. So you find out you have this gene. The gene's associated with a more aggressive form. And so can you just educate me and the listeners on the various types of cancers? I mean, you mentioned hereditary cancers. What other kind of categories are there? How are they organized?
So we organize them sporadic, familial, and hereditary.
Okay.
So let's just talk about that for a second. So a sporadic cancer, the way I describe it when I'm counseling patients, is you're an 80-year-old guy, you're a farmer, you drive around in your tractor all day out in the sun, not wearing any sunscreen. You're smoking in your tractor. You spray your crops with Roundup or whatever.
Surprised this guy's made it to 80.
I know.
Jeez. Nice job.
I know. And then he eats a non-grass-fed beef that's probably got some of the Roundup on it.
Yep.
Every single night, red meat, and he drinks about 8 gin and tonics every night.
Jeez Louise.
So he's bombarded himself with lots of chemicals.
Yep.
So many of the genes that we test people for are what we call tumor suppressor genes. So we all have them. I have a BRCA gene. You have a BRCA gene.
Okay.
I just happen to have a mutated one, and I hope that you don't.
Yeah.
But so in a guy like him, what's supposed to happen is the cells are dividing and they're making abnormal things because of all these exposures. So the BRCA genes should hopefully swoop in and say, hey, cell, you're you're misbehaving. You better fix yourself or I'm going to kill you. So that doesn't happen. So then the cells continue to grow and divide, and then that turns into a cancer.
Okay, got it. And that's sporadic.
That's sporadic.
Got it.
A familial cancer, and these are kind of the frustrating group because we see a lot of cancers in the family for some reason, but we don't have an explanation for it. We've done genetic testing and the whole family's negative, but we're still suspicious something's going on.
Mm-hmm.
So is that maybe a gene we haven't identified yet? Or the way I explain it in the office, because most people know about Butte, Montana. So Butte, Montana is a mining community. Yep. And so I say, or maybe all these cancers are because your whole entire family worked in the mines in Butte and you were exposed to the same...
Same exposure across the family.
Right.
Yeah.
So that would be a sporadic cancer. And then familial or hereditary cancers are cancers that you inherit a bad copy from a parent, and then that predisposes you to having a higher risk of cancer in your lifetime at a younger age than what we would normally screen people for.
Sure. Yeah. Well, in your 30s, I mean, that's early. And are there differences in sort of aggressiveness across these categories that are stable?
The familial or the sporadic or the
hereditary?
Familial,
sporadic, or hereditary. Is one worse than the other, I guess?
Hereditary cancers definitely are generally more aggressive.
Okay.
Yeah.
And I guess you get them younger typically, so that can be, yeah.
And there's not as many treatments sometimes for them. So I mentioned the triple negative breast cancer, and a lot of people have heard of women taking tamoxifen when they have breast cancer.
Okay.
So that's a drug that we give people that are estrogen receptor positive. In a triple negative cancer, your estrogen is negative, so taking tamoxifen might not help you for that cancer.
Okay. So I'm already confused, and I can't even imagine how much more confused I would be if I actually had cancer or had been given the diagnosis. Your head just must be spinning, and you're whipped up into this sense of your own mortality, but also a world of chemistry and medicine and bureaucracy that's got to be so hard to navigate. So I'm feeling like maybe this is the genesis of Ava Health.
Yes. So I'm a huge believer in educating patients, and I do it with visuals, probably more because I'm a visual learner.
Sure.
And when I get, I have a pelvic model, I have a breast model, and what the inside of your breast looks like. So when I get a new breast cancer patient in my office, it's one of my favorite things to do. Not that they've got breast cancer, but I can de-escalate fears in a patient really quickly with a little education. So I love to go through their pathology report with them and explain, because your primary care provider is probably the person that ordered your mammogram. They call you up and say, okay, you've got an invasive ductal breast cancer. The only words you probably hear are invasive and cancer.
Yeah, exactly. Those two, invasive
and when
cancer.
you hear invasive, you probably think, oh my gosh, that's all over my body now if it's invasive.
Yeah, it sounds awful.
Yeah. So I do a little bit of breast education as far as what the inside of their breast looks like so that we can talk about what invasive means, what ductal means. Here's what the inside of your breast looks like. So that's probably one of my very, very favorite appointments because those patients come in white-knuckled, scared to death. And they leave my office usually hugging and laughing because they've got some knowledge, which is super powerful. I also do the genetics appointment at that time and schedule them with whatever providers they want to see. One of the beauties of Ava Health is it's a private practice, so I don't have to necessarily refer within my own hospital system because I'm a private practice and I'm the only provider. So I think I feel like we have to help our patients know what they kind of want in a provider, and which hospital system do you prefer? Do you prefer male or female providers? Things like that. So we talk about that before any appointments are scheduled,
Sure.
And then I usually get their appointments scheduled. I have a huge collection of business cards in my office, and I start this notebook for them, and I start with the business cards of all the patients, the people that they're going to be seeing, because they've got me, they've got a medical oncologist, a radiation oncologist, a surgeon. There's just a lot of things that need to happen. Sometimes people need breast MRIs. Sometimes they need additional imaging. So having that all in one place for them and to know what people's names are and where their offices are, I think is a cool thing to have. And then we start with, let's talk about the statistics of breast cancer, because most people think, oh my gosh, it's cancer, it's growing really fast,
Yeah.
I need to get in or I'm going to die. So we talk about the rate of growth, and then we kind of talk about breast anatomy. We talk about their pathology report, and I help them understand what those words mean. So, it might be invasive ductal breast cancer, grade 3, stage whatever, and
Yep.
by then you can just see they're
Glazed.
glazed. And so we talk about all of that and I tell them it's like learning a new foreign language. And I don't expect you to speak it instantly, but let's start introducing those words. And I feel like then by the time they get to the medical oncologist, the surgeon, they've at least heard those words and know what their pathology report means. So they're armed with information when they go into those appointments instead of, I remember, I'll never forget one of my appointments when I showed up. I knew I was going to lose my hair, and that was terrifying as a 38-year-old young woman.
Mm-hmm.
And I remember thinking they took my picture when I got to the doctor's office, and I was petrified, and I'm like, oh my gosh, I'm just not even going to look like myself. And so they wanted to take a picture so they'd remember who I was.
Yeah.
So that was super scary. And then we talk about the people on their team and what their role is. And then I give them some resources and ask them to call their health insurance and ask for a patient advocate that they can speak with, because I can't know their policy. Their other physicians can't know the ins and outs of their policy. And then that advocate can help them with some insurance questions.
And so I got two questions that are kind of related. I guess I'll ask the kind of second one first. How does a patient find you? I mean, how do you acquire new people into your practice?
So provider referrals.
Okay.
So primary care oncology providers refer to me wanting the genetics done on their patients. Genetics is its kind of own specialty in itself.
Okay.
So it's hard to keep up on everything. So, I'd rather them focus on the chemo drugs and the cancer treatment.
Sure.
And let me do the genetics piece, and I'll help get you that
Yep.
information. Because now we also do have medications that we use in people that are like BRCA positive and things like that.
Yeah.
So
So you have sort of a particular medical practice scope, I guess, or a differentiator there, right? You provide this genetics service that others either don't or think their patients need, or
Mm-hmm.
that's an entry point.
that's an entry point. Primary care providers is part of the physical assessment of every year when you go in for your
Yep.
annual exam. Family history's on there. So hopefully, a savvy little provider is going to be like, wow, if you or a provider thinks, wow, that's really crazy that this family has people younger than 50 with cancer, you need to take note of what you're thinking about that and be like, maybe this is someone that Michelle needs to see. So that's one way. I see patients, and then they refer a friend who they knew who had breast cancer when they were 30 and now they're 50. So they've survived their initial cancer, but young age at diagnosis is a red flag for testing.
Sure.
So they might say, oh, I talked to her, you should go in and see if you meet criteria for testing.
Okay. And then I guess the second part of that is, and you answered part of that. So part of what you do that's distinct and provides kind of some differentiation is this genetics expertise. But I'm also hearing that there's sort of this helping a patient navigate the system.
Mm-hmm.
And that, I'm assuming that motivated your interest in launching your own venture like this.
It did, and it was because of my work as a nurse navigator
Right.
before, and I didn't have that. I felt kind of stupid as a nurse, and I worked in an OBGYN office. I worked with women when I was diagnosed, and I had no idea what any of that stuff meant. And I just remember feeling so overwhelmed. And so that's why I love to get people in right when they're diagnosed because it's usually at least a week and a half before you get to any of the oncology providers, and you are terrified.
Yeah.
So
And you probably feel like that week and a half is just, we were wasting time. You're
right,
sitting there
and
just dying.
and the cancer's just growing.
Exactly.
Yeah. So I think I personally feel like there should be nurse navigators in every area of medicine.
Uh-huh.
Knee replacement, hip replacement, diabetes, wherever, because the general population doesn't know what their resources are. And it's nice to have someone that's an expert in that area help you kind of start understanding the information so that you can choose providers, choose treatments, choose how you want things to happen.
Absolutely. My mother just went through a bypass procedure maybe 3 months ago, and it came about rather suddenly. She didn't have a heart attack, but they found major blockage, and she was in for surgery within a couple of days. But yeah, just the navigation of all of that, and the 20 different meds you're on afterward, and the various stages of rehab, and like there was no time to sort of adjust her life, and all of the, like you said, the patient goes through all this. There's a stress response cognitively that she really benefited from. In this case, a social worker at the hospital really guiding her and my dad through the whole process.
Yeah, and social workers are a big part of, I think, oncology care too, and the mental health piece of all of that, because it's a super stressful time.
So a patient gets referred by a primary care physician. They're sort of feeling in crisis or something similar or something, and they come to you, and you help them understand their diagnosis, but also provide this genetic counseling piece as well.
So I just want to talk just for a second about different practitioners. So genetic counselors are different than what I am.
Okay.
So I'm a nurse practitioner that does genetics. So
Got it.
A genetic counselor has an undergrad in usually some type of biology field, and then they get their master's in genetic counseling. They can see all kinds of, there's all kinds of genetics things besides cancer. So they can see those, and generally most of them do. So there are now, there were certifications for nurses a few years ago, and I don't know, there was some problems with them not thinking that there was enough nurses interested, so the certifying body quit certifying nurses, and that's kind of why I went to get my master's as well, because I wanted to be certified in genetics, and I wanted to make sure I wasn't practicing outside my scope, which I wasn't as a nurse because I could educate, but I just couldn't take those other steps forward to write my own orders and take care of the patient and recommend how they should be taken care of.
Okay.
So there are nurses in genetics now. We have an organization called the International Society of Nurses in Genetics, and so they are in the process, should be out like the first part of December, they've created another program now so that nurses can be certified.
Okay.
And there are nurses that are certified from the certifying bodies that we had in the past. So I went to a super intensive genetics course through the City of Hope in Duarte, California. It's a big cancer research place, and it's phenomenal. So I took a course last fall from November to February. And then I went to City of Hope for a week and had more training in didactics and case presentations, and then went back to their yearly conference.
Wow.
So I'm a part of that City of Hope community of practice. So I have connections all over the world. There were people from Brazil and all kinds of places in my class. So I have that as a connection. And weekly on Wednesdays, I often listen in on their people have heard of like Tumor Board, where we present cases. This is just kind of a genetics one. So if I have a case that is unusual or difficult, or I want to bounce some ideas off of experts, then I can present a case there and over the internet, and it's just super wonderful. I have a fascinating case right now. It's a mutation called Li-Fraumeni, or TP53.
Okay.
And the risks of cancer for that patient is 97% chance in her lifetime that she may get multiple cancers.
Wow.
So finding out that she was positive is pretty powerful information for her, because she's in her mid-30s, and she's never had cancer. But now we can be proactive with screening her differently, so hopefully she doesn't get cancers in her lifetime, or we catch them at an earlier stage before they're all over her body.
Yeah, as I'm thinking about that, you get sort of an indication you have that gene, and it comes with it this 97% chance, like you said, of contracting a cancer in your lifetime. So one thing you do with that is what you mentioned. You go through more regular screening. What else do you do with it in terms of lifestyle? Can you to me that would sort of motivate me to do something. I'm not quite sure what, but I'd feel like I had to do something. A New Angle is brought to you by First Security Bank and Blackfoot, two cool companies doing awesome things all over Montana.
Hi, this is Aspen Runkle. I'm a graduate student at the College of Business and a marketing intern for the podcast, and you're listening to A New Angle.
Yeah, I just had my last patient I saw right before I came today has an MSH6 mutation, which is colon, uterine, stomach, ovarian. It can do some bladder stuff too. So she's obese. And so we had a long chat about diet and exercise and keeping her healthy through that, and with other testing and keeping an eye on her. And here's what you need to look for. Taking a baby aspirin a day is going to help her too. So, and it's funny, well, it's not funny, but I ask my patients, like the TP53 lady with the 97% chance, I ask them, are you glad you know? I mean, that's a super scary one to have. And she really is. Her sister was diagnosed with breast cancer at 24 years old and died at 26. And her father and her paternal grandfather both died of pancreatic cancer. And when she went back and thought about it, her sister also had a probably adrenal cancer when she was 2, which is another part of that syndrome. So it's powerful information, she feels like, because she hasn't had cancer yet and she can do something about it.
Do we know much about how these mutations come to be? Like why people, I mean, there's it's hereditary, I guess, but why is it there in the first place?
That's a really good question.
Yeah.
What came first,
That's
the chicken or the
answer,
egg?
right?
Yeah. Some of these, like that TP53 one is an interesting one because it can be a spontaneous mutation and it happens in the embryo stage when things are first forming. There can be like a little blip of a mutation, and then in TP53 it can we call that a de novo or a new mutation. So it's super interesting. But most of the time they're inherited from a parent.
Okay.
And so for instance, my mutation came from my mom. There's other red flags we look at too, like Ashkenazi Jewish individuals.
Sure.
They have a higher incidence of being BRCA1 or 2 positive. So I come from an Irish-Polish family. So my mom is who I inherited my mutation from. So every time she made an egg, that egg either got her bad copy or her good copy, because you have 2 copies.
Yep.
So I happened to get her bad copy. We're pretty sure my sister Sherry had her bad copy due to her age at diagnosis, and she was estrogen progesterone negative. My brother, who is a male, got her bad copy.
Okay.
And then my younger sister got my mom's good copy. So every time an egg is made from my mom, you either got the bad copy or the good copy. So it's not like, there's 4 of us kids and half of us got the bad copy and half got the good copy.
And has your brother been ill yet?
Nope. So my mom is 78 years old.
Okay.
So this is just a light in the end of the tunnel almost. She's 78 and she's never had cancer. So she's what we call a pre-viver. So that's a person that knows they have a hereditary mutation, but they never have had cancer.
Okay. And is that just, random walk for your mom, or she didn't know that she had this genetic mutation until after 96 or 7, whenever you said that test was created. So she's just been fortunate, or she's lived a particularly healthy life, or some combination of the two?
Well, I think she's been lucky. She hasn't necessarily lived a healthy life. She was a former smoker and drinks some alcohol.
So she's beating the odds.
So she's beaten the odds.
Yep.
My brother is also what we call a pre-viver. So he's 55 and he's never had cancer. He could probably stand to lose a few pounds.
Yeah.
And then my younger sister, Bridget, who found out she was negative, is, she's probably the healthiest one of all of us, actually. And so because she's negative, then her kids don't need to be tested as far as her side of the family is concerned. Now, my brother has 2 kids, a boy and a girl. So I like to talk to my patients, too, about some of the psychological and social aspects of testing, because it can bring out things in families. There's some strained relationships in my family, and probably the tip of the iceberg was the whole genetic piece of it. Plus, you can find out things like your mom's not really your mom, or your dad's not really your dad, and things like that.
Sure.
So we talk about that. My brother has 2 kids, and I'm not sure if he's told them. And you have to think about, is this a good time for them to know? They're 25 and 21-ish, so we're not going to really screen them any differently yet. But the 25-year-old male, we wouldn't start screening him for probably another 10-ish years or so for prostate stuff. But if he was my patient, I would definitely make sure he knew the signs and symptoms of some of the cancers. But maybe we don't really need to test him yet because we're not going to do anything different. But if he decided he wanted to have children, we could do some pre-implantation genetics and in vitro fertilization so he didn't pass the mutation on to his kids.
Okay.
But then that's a whole nother moral, ethical, religious thing that a patient has to go through. And then his daughter is 21, and we wouldn't do anything differently for her if she was positive until she's 25, and we would start with breast screening. And so I worry about her because a lot of times we know in the next generation, the cancers happen earlier. And so my sister was 30, and this little niece of mine is 21. I also have a colleague who works in the industry for one of the genetic testing companies, and she's a nurse in genetics. She works for one of the genetic testing companies, so she knows tons of stuff. And she's positive, and she knew her 25-year-old daughter was positive, and this daughter was getting screened already with breast MRI. And in the interval between her 2 breast MRIs, she got diagnosed with breast cancer. So it can be super scary. So you have to decide, what are you going to do with that information? Is it going to terrify you and you're going to be at the doctor every day wanting a scan? Or are you going to be proactive and use that information to be powerful? My sister had 3 boys. As far as I know, the oldest and youngest one have not been tested. The middle one was tested, and he's negative. It took him 2 years to get an appointment with a genetic counselor to be tested. He lives down in Florida, so that is super crazy. So powerful news for him. And then I have 2 daughters who both got my good copy, so they're negative. And they're what we call a true negative because we know there's a mutation in the family and we know they don't have it.
Okay.
Same thing with my younger sister. She's a true negative. But then she's the only one of the 4 of us that's negative. So kind of had a little guilt about that. And,
interesting. Yeah. I could tell. Yeah. So when somebody, so you help patients of yours sort of navigate if and when to get some of this testing done. And then, like you said, once you have the information, it can be powerful. How do you help patients walk through the layers upon layers of issues with acting on that information or not acting on it?
Mm-hmm. So when I have my patients come back in for their test results, I don't generally, unless it's a cancer patient going through treatment and we're down to the wire of their surgical decision making, should they have a mastectomy or should they have bilateral mastectomies? Or should they have a lumpectomy or bilateral mastectomies? So I generally make them come back for appointment so we can go over the full report. I'm a huge believer in what we call panel testing, where we're testing for other genes. A lot of people know about the BRCA1 and 2 genes, but there's other genes that cause breast cancers. And when you start looking at family histories, you've got a breast, ovarian, prostate. So you've got to hit all of those genes because there's many of them. So I'm a panel tester. So I generally test at least 35 genes. And there's other ways to look at risk about breast stuff that we can talk about, and breast prostate stuff that we can talk about. But I bring them back in. We go over what their mutation is and where the gene is and what the cancers are associated with that gene. We also look at the report again, and I've educated them about this in our pre-counseling session of what the different genes are that we tested them for, because I want them to understand that, because a lot of people say, oh yeah, I had BRCA testing. Okay, well, did you have just BRCA testing? Because this day and age, that's not enough. you need to have these other genes looked at. If that's the only cancers you have in your family and you just want the breast panel, that's okay. So we have that conversation. Panel testing's been out since 2014. And as we get more information in about some of these other genes, it's allowing science to move forward in thinking like maybe does one of those colon genes also have a little component of breast cancer to it? Do we need to be thinking about that? So I talked to them about when they're doing a panel test that they're adding knowledge to science.
Okay.
One of the things that reasons not to do a panel test is something called a variant of uncertain significance. So it's a genetic misspelled word that maybe we don't have an answer for yet. Most of the time, the labs have them as negative, on more towards the negative side than the positive side. So we have to watch that. And then as the labs get more information on that particular misspelled variant, it'd be like, let's say the word is supposed to be spelled cows, C-O-W-S, but instead yours says cows, K-O-W-S.
Okay.
Well, phonetically, we can still sound that out to spell the word cows. It's just an unusual variation.
Sure.
So then the lab's job is to figure out, is it harmful or not? And is it cancer causing? So the more genes we test, we get those variants, but then we get information about the variants so we can reclassify them to, are they positive or are they negative? So there's that whole panel testing piece of it. And then we go through all the genes they were tested for. We go through the mutation they have, what the cancers they cause, what's the incidence of those cancers, and what are we going to do to screen you for it? And what do you need to tell the rest of your family?
Yeah, I guess that's a piece I'm thinking about. Like, what do you tell the rest of your family, your siblings, your children, or if you haven't had children, this might have an influence on your decision to have children?
To have children or to do in vitro.
Yeah. So how do those conversations go? I mean, do you have like a framework you use to help navigate these sort of moral quagmires?
Yep, I talked to them about all of those things. And, that's one of the things brings up a point with insurance companies, because insurance companies are getting, where they don't want to cover stuff. And it's really frustrating. So you have to have those things documented that you actually counseled the patients on them, which is what you should do if you're doing genetics appropriately. If you just went to your doctor and they're like, here, spit in this thing, let's send your genetics off. That is not informed decision-making or shared decision-making, and I'm a huge believer in shared decision-making for my patients. If you're a person that's going to make you worry too much, then maybe you're the type of patient that we don't test.
Yeah, and then I'm thinking of this world where the insurance company has access to your genetic information, and yeah, that seems like a very fraught situation with them being able to maybe set rates according to your genetics and things like that.
Well, actually, there's a law. It's called the Geno Law.
Okay.
And your health insurance cannot discriminate against you based on your genetic status.
Yeah.
They can't. I actually had a health insurance company ask me to send my patients' results the other day, and I called them up and said, "Yeah, no, you can't do that because of the Geno Law. Would you like me to send you a copy of that?" And they were like bugging the heck out of me to send those. And when I called back and said that, they're like, I haven't heard from them for a week now.
Interesting. Were they? I mean, they can't have not been aware of the law. They're just maybe thinking that you might not be.
Maybe, I don't know.
I know.
So we talk about that, and then life insurance isn't a piece of that. So I do kind of talk to my patients about that, and maybe you want to make sure your life insurance is in place. I have never met anyone that's had a life insurance issue. I haven't, and I got a new company this year. So, yeah. Wow.
Well, okay. So I just got to assume these are going to be really hard conversations.
They are, but for most patients, they want to know, why did I get cancer?
Yep.
I wanted to know, did I not eat enough organic food? Did I not do this? Did I not do that? So sometimes in these families, especially with lots of cancers, we see answers, and that makes people feel okay. And then back to the whole knowledge is power thing, because a lot of these families live in fear of having all those cancers. So when they finally really do have a plan, they feel better about it.
Sure.
And there's a lot of education about it. I ask people when I tell them, that they're positive, are you glad you did the test? And most of the time they are. I can't think of anybody that hasn't.
Yeah, I mean, generally more information is good in this.
Yeah, and before I have them spit in my little thing to do the test. It's just a spit saliva test.
Yeah.
I say, are you sure you want this information? What are you going to do with it?
Right. That's important to think through. I just remember with our children, we had various tests when my wife was pregnant, and the choices of whether or not to have those tests and what the results could tell you or not tell you. And yeah, you sort of had to run through the litany of decisions. Like, what are you going to do if you get a positive on this?
Yep.
Is it going to change your decision making? Anything? It's complicated.
You might not terminate a pregnancy,
Right.
but you want to be darn sure that you're in a facility, like let's say it's a Down syndrome baby. Sometimes they're born with heart issues. So you might not terminate the pregnancy, but let's make sure that you're in a facility that can take care of that baby when it's born. Let's watch the baby, make sure it's growing. Let's watch its heart, all those things with ultrasound.
So I want to be respectful of your time, Michelle. Can you give, as we kind of close here, what would be some of the best tips you could give the listener if they want to be a previvor or have one of their friends and family be a previvor?
So Thanksgiving weekend, so this is perfect timing, is a great time. Families around, you're sitting around the table to document your family history.
Okay.
Because there's a lot of people that don't. My parents' generation did not talk about those things. It was taboo, especially when you're talking about breasts and ovaries and
Sure, like who
uteruses
died
and
of what,
prostates.
when, and
Yeah,
all
you
that
want to
stuff.
know how they were related, how old they were when they died. And this is an important piece, too, in clues that I look for. Did someone die early, like 24 years old in a car accident? They didn't live old enough to develop the cancer. So I look for clues like that.
Sure.
Is it a small family? We call that a truncated family, where there's not very many individuals in the family. Is it someone that's adopted? That's a tricky one because it's hard to get those covered sometimes. But
Yep.
so document who the person is, and start with I do a 3-generation family history, so it'd be like grandparents, parents, siblings,
Sure.
and your children. That'd be 4. So, document age that they died, what they died from, and then aunts, uncles, all of that, and just keep that and give it to the rest of the family so that as time goes on and people die, you know what your family history is. If you're going to adopt out a baby, please give that information to the adoptive parents. I mean, it's great info. So family history is a huge Thanksgiving thing.
Okay.
There's a thing called My Health Portrait where you can go on and actually document that stuff. So things to look for if you are concerned. I do have a hereditary cancer quiz on my website, which is www.avahealthllc.com, and Ava is AVA. It's actually my first name, and it means the voice for others, so that's why I chose that name for my practice. So you can go on there and take this hereditary cancer quiz, and then that gets emailed to me, and if you're positive, concerned that there might be something going on, then you come in for a genetic cancer risk assessment, we call it, GCRA, and then we determine if you meet criteria for testing, or maybe who's the right person in your family to test. We usually like to test higher up on the pedigree. So like my mom would have been a great person to test, but there weren't any cancers before my sister and I, because if she's negative, then all of her children would be negative. But then if she's positive, each child has a 50-50 chance.
Okay.
So we look at who's best for testing and then go from there.
Well, Michelle, this is sort of fascinating, horrifying, and comforting at the same time.
I know, isn't it crazy?
It's such a swirl of emotions, and I'm not even really in it, fortunately, for the time being, and hopefully it stays that way for a long time. But thank you for this work.
Yeah. One of the things I like to say, too, is, especially for cancer patients, the decisions you make in the beginning of your treatment affect you the rest of your life. So I initially had, you remember, my stuff was all when it very first came out.
Yep.
So I had a lumpectomy. Because I had a lumpectomy, I had to have radiation, and I had chemo. So after a few years of finding out some information, I discovered that my chance of getting breast cancer again in my lifetime was pretty high. So I went back and had bilateral mastectomies and didn't have the options of implant for reconstruction because of the skin from the radiation. So I had a big surgery called a tram flap, where they use your rectus muscle and fat from your belly and skin from your belly to create your breast mound. So those decisions that were all made in the beginning of my treatment have affected me the rest of my life. And I'm a 21-year survivor right now. So that's what I like to talk to patients about in those initial diagnosis appointments is to, this can affect you. You need to think about what you're choosing and ask your doctors, your oncology providers, these questions.
Well, it's fantastic that, I mean, it seems like you're filling a critical need here with helping people navigate this super difficult, terrifying time in their lives and hopefully get through it as best they can. So where can people go if they want to learn more about Ava Health?
So they can go to my website, www.avahealthllc.com. They can call my office, schedule an appointment, ask a question.
And go from there.
Go from there.
All right. Thanks, Michelle.
All right. Thank you. Thanks for having me and letting me blab for a whole hour about genetics because I'm a nerd about it.
It was super. I loved every minute.
Thanks.
All right. My head is spinning a bit from that conversation. Hopefully, you'll never need Michelle's expertise. But if you do, you know how to find her. Okay. Coming up next week, we have number 11 in the Sea Change series, and I'm super pumped about it. It's a conversation with the amazing Sarah Calhoun, founder of Red Ants Pants and all the associated awesomeness. Stay tuned for that one next week. Thanks for listening to A New Angle. We really appreciate it. And we're coming to you from Studio 49, a gift from University of Montana alums Michelle and Lauren Hansen. And remember that A New Angle is supported by CED, Consolidated Electrical Distributors. These guys pretty much sell anything electrical you would ever need, but they also hire a ton of our students. If you want to learn more about jobs at CED, visit cedcareers.com. Before we go, I want to thank some important peeps, executive producer Stefan Borsum, and interns Aspen Runkle and Max Gibson. Huge thanks to VTO, Jeff Ament, and John Wicks for the tunes, and finally, props to Jeff Meese, our master of all things sound. Finally, if you have any questions, suggestions, comments, insults, whatever, please email me at anewangle@umontana.edu. Help us spread the word, and be sure to use the hashtag #anewangle when you do. Thanks a lot, and see you next time.